Onc Live Insights is a video editorial program produced by Onc Live.
Bone marrow biopsy is a controversial aspect of this disease. The bone marrow biopsy historically was routinely done in anybody who had a cytopenia, low platelet count. We now know that if in fact there is a normal appearing blood smear in terms of the white cells and red cells, it is isolated thrombocytopenia, and the other considerations that we talked about, meaning evaluation for secondary causes such as hepatitis C infection, HIV infection, problems with antibodies, and a history that might suggest another process such as lupus erythematosus or any other potential secondary things such as chronic lymphocytic leukemia, which can be made on review of the smear. All of these other aspects excluded, there really is no reason to consider having to do a bone marrow biopsy. One should consider bone marrow biopsy when one is refractory to standard treatments. One should consider bone marrow biopsy particularly in the elderly. One is because many of them actually have small clones of B lymphocytes that are very similar to chronic lymphocytic leukemia B lymphocytes. And one would consider bone marrow biopsy if there's any other abnormalities that one sees on the smear, such as some dysplasia of the white cells, or if there's an anemia that cannot be explained by bleeding or iron deficiency. So you limit the bone marrow biopsies to those groups alone, and in fact, in the end results is that probably today, as opposed to historically, maybe only about 20% of patients with a diagnosis of immune thrombocytopenia really have an indication for a bone marrow biopsy. Historically, we talked about acute immune thrombocytopenia, which was frequently thought of as the pediatric form. It was self-limited in the majority of cases. And then chronic form, which was more common in the adult population. The newer definitions talk about an acute phase that lasts for 3 months. During that period, about 50% of children will have a spontaneous remission from their severe thrombocytopenia. And usually these are individuals pre-adolescent. Then there's a persistent phase, which goes from 3 months to 1 year. In that period of time, in the pediatric population, close to 80% of children or very young adults may have a spontaneous remission. Approximately 20% will go on to develop chronic immune thrombocytopenia beyond a year. In the adult population, about 15% of individuals treated frequently with corticosteroids may subsequently have a spontaneous or complete remission when the steroids are withdrawn. So 15 to 20% of adults in that period of time. Beyond a year, refractory individuals truly remain refractory in the majority of cases. There are very few spontaneous remissions in adults beyond 1 year, and that's when we define them as having chronic immune thrombocytopenia. So the pediatric population has other important aspects in the history. One is that frequently, in about 2/3 of the cases, it's preceded by a history of a febrile illness, as opposed to the adult population where the onset may be insidious over months or sometimes weeks of bruising or increased menorrhagia in a woman, no episodic nosebleeds before the diagnosis is made. But usually there's no febrile or major illness that precedes the onset.
There's certain things that can happen during pregnancy. There's something called incidental thrombocytopenia of pregnancy. The platelet count normally drops during pregnancy, usually by about 10%, but sometimes more than that, and sometimes in a patient who has sort of a baseline platelet count that may be in the normal range but close to the lower limit, during pregnancy their platelet count will fall below the lower limit and they'll be defined as thrombocytopenic, and sometimes it drops more than others. So that usually gets better after the pregnancy is over, but that's another thing in the differential diagnosis